Hi, I'm Dr. Brian Kaufman, a retired family doctor and CLL patient myself. I'm the Executive Vice President, Chief Medical Officer, and co-founder of the nonprofit CLL Society. You want to introduce yourself, please?
Yeah, my name's Shazad Mustafa. I'm an allergist and clinical immunologist in Rochester, New York. Take care of children and adults, but I have a special interest in secondary immune deficiency in individuals with B cell cancers and chemotherapy.
And Dr. Mustafa, uh, a lot of immunologists deal with uh, allergic problems, and you do that, but the big thrust of your work is dealing with diseases of the immune system. And CLL is a cancer of the immune system. So can you explain that in some patient-friendly terms, what that means and what impact that has, especially during the pandemic?
Yeah, so CLL is what we call a B cell cancer. Our B cells make antibodies. And in CLL, it's kind of antibodies gone wild. So the B cells are replicating, and there's a lot of them. But unfortunately, even though there's a lot of them, they're kind of dysfunctional. They don't work as well. So that's kind of what drives CLL. And then as a consequence of that is if your B cells are too many in number and not enough in function, you have an inability or a suboptimal ability to build antibodies, which we all know, especially through the COVID pandemic, that we need antibodies to fight infections. So individuals with CLL and other B cell cancers like lymphoma or multiple myeloma are at significantly increased risk for infections, and that it remains a significant problem in these individuals.
So one of the big pieces that we're learning about now in the pandemic has forced our hand is the role of preventative care. Because for CLL, as you point out, infections are a huge problem, especially respiratory infections, pneumonias, and COVID causes pneumonia. So talk to us a little bit about preventative care and why that's so important in your role and the hematologist's role in disease management for a CLL patient.
Yeah, so every time in medicine, prevention is always better than treatment, right? We want to be out ahead of it. And I think the first step of prevention, Brian, is awareness. And just being aware that even at the time of diagnosis for CLL, and many individuals take a watch and wait approach where you don't even need therapy, you just watch and monitor blood work. Even early in the condition, there is often evidence of suboptimal immunity and decreased immune responses and antibody effects. So I think awareness is important, and I think we would benefit from studies and research that have give us a more uniform approach. Some individuals, like myself, check an immune evaluation for every CLL patient, even whether they're getting sick or not. Others wait until they get infections. We need a little more uniform approach. And then once you start evaluating someone's immune system, if everything is intact, that's fantastic. But if there's glitches in the immune system, abnormalities in the immune evaluation, there are ways to intervene. It's not just an academic conversation. We actually have therapeutics and medications that can help us intervene and hopefully cut down on the risk of infection.
Well, one of the things that happens a lot in CLL patients when they do get evaluated is they have your immunoglobulin levels checked. So if they're okay, am I okay? Is that the end of the story?
No, so that's a leading question, right, Brian? So
Right.
immunoglobulin levels are a great place to start. And again, many individuals who've treated people with CLL check immunoglobulin levels, but some don't. So that's a great place to start. The problem is the level gives you the amount of your antibodies, but it doesn't tell you the function. Okay, and there is good science. There's good research that shows even individuals with CLL who have normal levels of immunoglobulins, they have suboptimal function. So as an immunologist, we're kind of trained to evaluate for function, and what we often do is evaluate for vaccine responses. We check your antibody levels to some vaccine, let's say pneumonia. We vaccinate you with a pneumonia vaccine, and then we recheck the levels 4 weeks later. And what you want to see is that level to at least double, but typically quadruple. And that really tells you about function. So we have individuals with normal immune globulin levels with poor function. And the opposite too, Brian. We have individuals with low levels, a small army, but very good function, preserved function. So I really think levels are a good place to start, but it's really the tip of the iceberg. I think for especially for individuals with CLL, we want to go a step further and evaluate for function. And now everyone's not created equal. I mean, this is certainly more important if there's a history of infections or people are getting sick. Maybe less important if there's no history of infections, but it's still very valuable information given that we know infections remain a huge complication.
And I would totally agree with you there that really it's what happens, because we both know people who've had very normal immunoglobulin
Yeah.
levels and had recurrent infections, and people who've had very low levels and never seem to get infections.
Yeah.
So, but what if you have both? You have a low level and you're having recurrent infections. There are replacement therapies available. Can you talk to us about what's involved in that, what the benefits are, what the risks are? And I understand that there's some new ways. These used to be given intravenously, but now they can give subcutaneously. So could you walk that through? If I'm a patient and I've said, listen, I've had pneumonia twice, and in the last year, what are my options? My immunoglobulin levels are low. Help me understand.
Yeah, so there are a
navigate
couple
that.
therapeutic options, Brian. Before we get to immunoglobulin replacement or antibody replacement, the most common prophylaxis against infections in CLL is actually prophylactic antibiotics. So that is an appropriate option for some individuals. And again, it's, you have to talk to the person in front of you. You can't, one size doesn't fit all. But I just want everyone to know that is an option, and actually the most commonly used option. But in individuals who are getting
So
sick,
let me just
yep.
stop you on that too. Doesn't that have somewhat to do, like I know that the sulfa-based antibiotic is sometimes used to prevent opportunist infections like pneumocystis. But doesn't that also have to do with T cell function, which is impaired also in CLL?
Yep. So CLL is primarily a B cell condition, as you know, Brian, which is antibody creating cells, but T cells are also very important. Our immune system is complicated. So we do use prophylactic antibiotics if there's obvious abnormalities in T cells. But even if you think your T cells are relatively normal and it's more of an antibody problem, there is a role for prophylactic antibiotics. And again, I think it's a discussion you have with the individual, most importantly, based on the history. Are they getting sick? And if they're getting sick, what type of sickness? Sinus infection that's treated as an outpatient with a week's worth of antibiotics is very different than pneumonia that lands in the ICU for a week, right? We have to think about all of this stuff. So prophylactic antibiotics are a consideration, but what you were talking about, if someone's had severe infections or recurrent infections and their antibody levels and function are low, we really do think about antibody replacement. Just like a diabetic can't make insulin, we give it to them. If you're not making appropriate antibodies and leaving yourself predisposed to infections, we can give you antibodies. It's a blood product. It comes from blood donation from several thousand donors just to make a single dose. So it's a very limited resource. We don't want to overuse it. And we infuse you antibodies and you kind of get what you can't make yourself. You're right, Brian. Historically, we use a lot of intravenous, which is typically given once a month, typically in a healthcare facility like an infusion center. It takes 3 or 4 hours. But, immunologists particularly are using much more of subcutaneous, which is more like an insulin pump. Individuals can easily do this on their own. It takes 2 or 3 sessions to learn it. And it can be done at home. It's not a long infusion, like 3 or 4 hours. It's about 45 minutes to an hour, depending on the dose. And it's generally once a week, Brian. But again, there's some flexibility. You can do it, honestly, small doses daily to even larger doses once a month. So the benefits are autonomy. You can do it at home at your own schedule. It is actually very importantly better tolerated, the subcutaneous version. There are less side effects. Both are well tolerated, but the subcutaneous has less side effects. Many people with the intravenous one once a month kind of feel yucky around the infusion, like flu-like symptoms for a day or two. The subcutaneous is better tolerated. And if you think about it, Brian, if you're infusing something once a month with a big dose, you get this big level, right? And then it trickles down, and then you do it again a month later. The subcutaneous is a little more steady level. So these are choices. I'm not saying one is better than the other or one should be the way to go, but I think it's worth a discussion for anyone who's thinking about immune globulin or antibody replacement or discussing this option with their providers. You should be aware that there are really 2 ways to deliver it, and there's pros and cons to both. Because I think sometimes historically we just kind of get used to doing the same thing. And there, in the CLL world, intravenous is far more often used than the subcutaneous.
Is this still a big unmet need in the CLL community? Do you see people that are not being taken care of in terms of their immunocompromised state?
Yeah, I still think it's an unmet need to standardize the evaluation of the immune system in the setting of CLL. Like I said, everyone does it very different. The labs that they check are different, and when they check them at the time of diagnosis, only when someone's getting sick, only when someone's getting real sick. So I think it's an unmet need to standardize this because I think a nice evidence-based approach for all patients is always beneficial. And then we do need to really study these interventions. I mentioned antibody replacement is a limited resource. It's a blood product. You don't want to be overusing it or inappropriately using it because there's often shortages nationally, and we are in a blood shortage right now. So we really want better studies to say everyone with CLL doesn't need this treatment, who would benefit most, and to prove that benefit, and then kind of go forward from there.
Any final thoughts that you'd want to share with the CLL community about their immune status or this trial in particular, or the role of an immunologist, or just take it wherever you want to take it?
Yeah, no, I think, like I said, I'm going to circle back to what I started with. The first step in moving any needle is just awareness. So be aware. I mean, the reality is any individual with CLL probably has some degree of glitchiness in their immune system. It might be mild or very close to normal. It could be severe. I think the first step is just talking with your provider who you trust, whether it's your primary, your oncologist, your hematologist, your immunologist. What does your immune evaluation look like? Should you have an immune evaluation? And then depending on what that shows, taking it from there. I don't think it's a one size fits all. I think that these are individual discussions, but the beauty of much of the immune evaluation is it's relatively straightforward blood work. It doesn't require fancy procedures or bone marrow biopsies that you may have had for other stuff, or fancy images or MRIs. It's pretty straightforward blood work that most people have access to. So it's just a question of awareness, completing it, gathering the data, and then going from there. And certainly it becomes obvious when people are getting sick and having frequent infections, but we'd rather get ahead of it. So even at the time of diagnosis or before that, I think there's a real argument to be made that this evaluation should be considered at that.
Dr. Mustafa, thank you so much for what you're doing for the immunocompromised community in general and the CLL community specifically. I'm so grateful for what you're doing and your involvement in this research. Thanks so much.
Brian, thanks so much for all your great work, and thank you so much for having me today.
Thanks.